A complete transthoracic echocardiogram relies on four primary acoustic windows to visualize the heart's anatomy and hemodynamics. Parasternal long-axis view, often called as plaques view, is typically the starting point for a transthoracic examination, providing a longitudinal slice of left side of the heart. Probe is placed in the third or fourth intercostal space just to the left of the sternum. Index marker pointed towards the patient's right shoulder. Key structures evaluated include left atrium, left ventricle, right ventricular outflow tract, mitral and aortic valves, aortic root and descending aorta, highly useful for differentiating between pericardial and pleural effusions. Parasternal short axis view. By rotating the probe 90 degrees clockwise from the plaques position, you obtain a cross-sectional view of the heart. Index marker is pointed towards the patient's left shoulder. Key levels evaluated. Aortic wall level visualizes the Mercedes-Benz sign of the aortic cusps along with the left atrium, right ventricular outflow tract and pulmonary wall. Mitral wall level evaluates anterior and posterior mitral leaflets. Mid-papillary level, the ideal level for assessing global and regional left ventricular wall motion. Apex level assesses apical wall motion and checks for apical thrombi. Apical four-chamber view. This window provides a comprehensive look at all four chambers simultaneously, making it the primary view for assessing chamber size comparisons and longitudinal function. Probe is placed at the point of maximal cardiac impulse, usually the fifth left intercostal space in the midclavicular line. Index marker is pointed towards the patient's left side 3 o'clock position. Key structures evaluated: left and right ventricles. The RV should normally be roughly 2/3 of the size of the LV. Left and right atria, mitral and tricuspid valves, noting the normal slight apical displacement of the tricuspid valve relative to the mitral valve, and interventricular as well as interatrial septa. Subcostal or subxiphoid view. This window uses the liver as an acoustic medium to view the heart from below. It is particularly useful in patients with COPD, hyperinflation or otherwise poor chest wall windows. Probe is placed just below the xiphoid process, pressing downwards and angling slightly upward towards the left shoulder. Index marker pointed towards the patient's left side for the four-chamber orientation. Key structures evaluated: all four chambers. The perpendicular angle to the interatrial septum makes this the best view for detecting atrial septal defect and patent foramen ovale. Pericardial space, the optimal view for rapidly identifying pericardial effusions and signs of tamponade physiology like diastolic RV collapse. Inferior vena cava, rotating the index marker superiorly allows a longitudinal assessment of the IVC diameter and its respiratory variation, which is used to estimate right atrial pressure. Once you have established the basic windows, a complete study relies on advanced and specific views to interrogate distinct myocardial territories, valvular hemodynamics, and extracardiac structures. Here are the key special views needed for a comprehensive structural and functional assessment. Expansions of the apical view. From the apical four-chamber view position at the point of maximal impulse, subtle probe manipulations unlock the rest of the left ventricle and the left ventricular outflow tract. Apical five-chamber view. From the apical four-chamber view, tilt the tail of the probe slightly downwards, angling the beam anteriorly. The fifth chamber is the aortic root and aortic valve. This is the primary window for using continuous wave Doppler to measure aortic valve gradients in suspected aortic stenosis, as the ultrasound beam is highly parallel to the LVOT flow. Apical two-chamber view. From the apical four-chamber view, rotate the probe counterclockwise about 60 degrees. Index marker pointing towards patient's anterior shoulder. Isolates the LA and LV without the right-sided structures. Specifically evaluates the anterior wall LAD territory and the inferior wall RCA territory of left ventricle, essential for calculating biplane ejection fraction via the modified Simpson's rule. Apical 3-chamber view, also called apical long axis view. From the apical 2-chamber view, rotate counterclockwise another 60 degrees, index marker pointing roughly towards the right shoulder. Looks remarkably similar to the Plaque's view, but interrogated from apex rather than parasternal window. Evaluates the anteroseptal and infralateral walls of the left ventricle. It is also excellent for assessing mitral and aortic wall regurgitation with color Doppler. Right ventricular inflow tract view. While the standard parasternal views show slices of the right heart, the right ventricular inflow tract view gives a dedicated look at the right-sided filling structures. Return to the Plaque's position, angle the probe inframedially, tilting the tail towards the patient's left shoulder to swing the beam into the right heart. Structures evaluated include right atrium, right ventricle, and the anterior and posterior leaflets of the tricuspid wall. The septal leaflet is usually seen in the apical 4-chamber view. This is often the best view to align CW Doppler beam with a TR jet to accurately estimate right ventricular systolic pressure and assess for pulmonary hypertension. Suprasternal notch view. This view moves away from the precordium entirely to interrogate the great vessels. The patient's neck is extended, often with a pillow under the shoulders. The probe is placed in the jugular notch with index marker pointing towards the patient's left jaw or ear. The ascending aorta, aortic arch, descending thoracic aorta, and the origins of the great vessels, brachiocephalic, left common carotid, and left subclavian arteries, are evaluated in this view. The right pulmonary artery is often seen in cross-section beneath the arch. This view is crucial for identifying aortic pathologies such as coarctation of aorta, aortic dissection flaps, or patent ductus arteriosus.